you want to talk a bit about the guidelines, how all these treatments have impacted the guidelines? Do you want to start with the...
Sure, with NCCN. Yes, I mean, here in the US, we turn to NCCN for clinical dilemmas quite frequently, and it's quite remarkable to see the changes that have happened as a marker of the times in HCC in this dramatic landscape expansion. But as of early 2019, we now have included in the guidelines based on these randomized phase 3 data sets and the immunotherapy promising or provocative early phase 2 data sets. In the advanced setting, for first line, we have lenvatinib as well as sorafenib as an option in the NCCN guidelines, and in second line, regorafenib, cabozantinib, ramucirumab for AFP high, that's a remarkable change compared to years past. And I should add, those were the level 1 evidence based on phase 3 trials, but I neglected to mention the pembrolizumab and nivolumab also are NCCN approved, guideline included options in the advanced setting after progression on sorafenib.
Yeah, so I've been involved this year in the guidelines that have been released by ESMO, both. And certainly the drugs you mentioned, the 5 drugs we have with phase 3 data, all of them are endorsed by both guidelines. And also checkpoint inhibitors at a less strong level of evidence, and particularly also strength of recommendation, because still the data is pending phase 3. So nivolumab is pending the phase 3 in frontline sorafenib-nivo, and pembro is pending the phase 3 in second line pembro versus placebo. But both are accepted according to the guidelines. One thing that is interesting, and I want to mention here, there was a lot of controversy among panelists, was the role of internal radiation with Y90 in advanced HCC and also in intermediate HCC. I have to say there was a long discussion, despite that the 2 trials that are out there are negative against sorafenib, but there's also a point of controversy that certainly was settled, particularly in advance. It is not recommended by EASL guidelines, but in intermediate still it is in the field, because there is phase 2 data suggesting that may improve the patient's survival, but still not phase 3 data. Something that is interesting, that the strong controversy was between systemic therapies and Y90 in advance.
Yes, I think the sorafenib and SARA data are examples of how difficult it is to study a device versus a systemic therapy, but in both cases the intention to treat analyses were negative for superiority.
In respect to the EASL and ESMO guidelines, I think they are not really significant changes in respect to AFP. There was always the question whether we should use AFP as a screening parameter, and this is in most guidelines not really recommended. It might add a little bit to select patients that are at risk to develop HCC, but it's a poor biomarker for screening. Therefore, there's some discussion whether we should include it in our screening programs or not. In respect to patients that have an established diagnosis of AFP, it was always part of our workup, I think, and we all have recommended before that AFP levels should be determined. I mean, it's a good marker if it's elevated to see whether a patient responds to therapy, or it could also be a marker to detect recurrent disease if the marker was elevated before. So in respect to more advanced disease, patients with an established diagnosis of HCC, in our clinic, AFP was always part of the diagnostic workup.
So JSH guideline will be definitely changed because of the success of REACH2 trial. Our guideline is changed online as soon as it is approved. So I presume the ramucirumab will be approved as second-line agent with elevated FA value. So definitely, JSH guideline will be changed.
Great, thank you.
And can you provide any personal patient experience that you've had with using ramucirumab?
We experienced around 15 patients in clinical trial, and different from other TKI, the patients do not have adverse events so frequently, so we cannot tell which is the real drug or placebo.